So depending upon the questions, there was a part of me is like, oh, that could be my car. So maybe you'll take it easy on me so I don't feel like getting towed was the better of the options than staying for questions. Questions? Hi, sir.
Was a very expensive proposition. So what's the reality cost versus benefit? I think we know the benefit, but the cost.
That's a great question. So when Chapter 58 was launched, there was a fear that it would be the equivalent of the big dig for the Commonwealth, and nothing could be further from the truth. This perspective that I'd give you on this is not just my own or the administration's. It's been verified and underscored by independent organizations like the Massachusetts Taxpayers Foundations and others. Chapter 58 has not been a budget buster. I think the foremost reason people thought it would be inordinately expensive for the Commonwealth would be that employers would drop coverage en masse to put their low-income employees in state-subsidized health insurance, but that's obviously not been the case. We have more employers offering coverage than we did previously. Still, the strong majority of coverage in Massachusetts is through employers. We've also been very successful in transitioning to subsidized, broader eligibility for subsidized coverage, having less of a need to support a former uninsured population through what used to be known as the uncompensated care pool and is now known as the health safety net. So that has helped offset the costs of expanding coverage. We've been very successful over the last couple of years of maintaining support at the federal level for healthcare reform in the Commonwealth through successive administrations and through administrations of different party. One constant has been strong advocacy for federal support for health reform, and the prior administration and this administration have done a really good job of maintaining that. All in all, that has kept the incremental net costs of health reform to approximately 1% of the state budget, which is good. And I think we always need to look at this as an investment in the health and productivity of the people of Massachusetts. I can't present to you statistics that tell you what a more productive, healthier worker means in terms of growth of our economy, higher tax receipts, but those are important results of investing in the health and productivity and financial security of our workforce. So it is a good deal for Massachusetts to keep our coverage levels high. That is not to suggest that healthcare cost containment isn't a significant challenge. It's why we quickly transitioned from launching an expanded coverage initiative to a series of laws culminating in Chapter 224, which have taken increasingly aggressive steps to try to rein in healthcare costs. We have an opportunity now with a state healthcare cost growth target, a new organization designed to oversee that target and spot and highlight market trends that either better enable us to achieve it or press against it and may cause us to go over the target. To push the delivery system in positive directions so that we don't have to choose between expanded coverage and affordable health care. The goal is to have both. Ma'am, did you have a question? Yep.
So does that equate to the minimum credible coverage being relaxed?
No. I was talking about, when I meant no coverage test, I meant right now, as you know, or actually no longer, but previously there was the fair share test. Mm-hmm. I was talking about tests that looked at whether or not the degree to which employers offered coverage of a certain type to their full-time employees, and if they did, they had no consequences, though there were paperwork burdens associated with that, and if they did not, they faced penalties. For small businesses that will under 50 employees, that will not be the case anymore. There is no more fair share, and the federal employer responsibility rule, looking at the level of the degree to which employers offer coverage to their full-time employees, looks only at businesses with over 50 employees. We still will have minimum creditable coverage rules in the market. among other things, to ensure sort of equity between smaller businesses and larger businesses in setting a baseline for what's permissible coverage in the market.
But in Massachusetts, the minimum credible coverage is more stringent than it is under the ACA, is it not?
They're very similar.
Okay.
The ACA essential health benefits rules and other benefit rules are quite similar to the MCC rules. The MCC rules are part of our individual mandate, and thus they affect workers no matter where they get coverage, small employers and large employers. The ACA rules around essential health benefits are largely concentrated on small employers. Maintaining minimum creditable coverage rules is one way of having equity in the Massachusetts market between smaller and larger employers.
Thank you.
Thank you. Other questions, sir?
You mentioned the 3-year phase out or in of the rating factors, and a lot of folks have been afraid that as of January 1, there's going to be this huge cliff, and certain groups will go up 20 or 30%, down 20 or 30%. Are all the rating factors that can you say this, quantify it? Is it going to be like a third and a third and a third going down? Are certain factors going to go way faster than others? And SIC code is one of the big ones that folks.
The big ones are group size factor, SIC code, and co-op, I think, are the big ones that are transitioned out. So the state's Division of Insurance has put out an administrative bulletin that provides exactly the methodology by which the state-specific rating factors that are not permissible in Massachusetts will be phased out. They also provide some examples, too, which I think would be helpful. It's probably on the DOI's website. I think, roughly speaking, though I'm not expert in the particulars, it is roughly a third, a third, a third. It's not like any given state-specific rating factor is completely eliminated in 2014. They are the ones that are in the state law that are not in the federal law are sort of gradually winnowed down over 3 years. Thank you. Was there another question over here, sir?
Hi, good morning. You're a brave man.
Or crazy.
I'm concerned, thank you.
A mix of the two.
I'm concerned about the sustainability of this expansion. I think we're spending in Massachusetts $1 million a day for unsubstantiated or no coverage or something to that effect. So where's its expansion? You're saying 206 million from the feds, but what happens when that goes away?
I'm not sure what you're referring to by unsubstantiated in this instance. So I'm not sure I can specifically respond to that. You are raising the issue about the $200 million in additional combined revenue and savings that benefit the budget this year by virtue of the ACA, namely because of higher federal reimbursement for certain populations and the fact of federal reimbursement for some populations that aren't currently reimbursed. That doesn't go away, it only grows. It will grow, number one, because in next year's budget we'll have the full year's benefit of it. And most importantly, right now we get a 50% federal match for basically our entire Medicaid population, maybe with the exception of children, which I think may be a little bit higher. That goes to 75% for what we'll call these expansion populations in 2014. I think over like a 4-year period till like 2018 or something like that, it grows from 75% up to 90% federal reimbursement for these populations. So that's why it's a good deal for Massachusetts and becomes a better deal. And interestingly, you're starting to see a number of states that, following the Supreme Court's decision last year, which gave states some ability not to do the Medicaid expansion called for in the ACA, there are a lot of states from the get-go that said, no, we're not going to do that. You're beginning to see some states, even some red states, turn around on this issue because when you look at it, it is a good financial deal for states. And frankly, it's a good investment in your state's economy, and it's a good investment in our people's health to make sure that even low-income people have access to coverage. Sir?
There's a promise of lower health insurance increases you give an update as to the Health Policy Commission and how they've been doing in that monumental task?
I will give you a little bit of an update, and maybe Jean, who is like me, a member of the Health Policy Commission's board, can speak a little bit to that on the panel. So the Health Policy Commission was created not much more than a year ago, if that. It's got off to a great start, though some of its most important work does lie ahead. In just a year, it's assumed responsibilities from our former Office of Patient Protection, handling some insurance matters there. It's sort of created the rules for collecting monies and distributing monies for grants to distressed hospitals. And it has begun the process of overseeing and offering opinion on significant market consolidations and transactions. You know, for example, you're beginning to see, or there have been, and now you're beginning to see reported to the Health Policy Commission, mergers, acquisitions among providers. The Health Policy Commission looks at them and determines if they will have a material impact on the market. If they don't, they proceed. If they do have a material impact on the market, while the Health Policy Commission is in position to stop them, it does have the ability to do a cost and market impact review, generate some information about the potential market impacts of those provider consolidations, and put the information out there for many people to sort of see, understand, and make policy and enforcement decisions on account of that, including the Attorney General's office gets referral of that information. The Health Policy Commission is very early on in these cost and market reviews. As they progress, we will really see what the organization can do in shining the light of transparency on market transactions that may or may not drive up costs. And further along the road for the Health Policy Commission, it will be looking at whether the state actually achieves the healthcare cost benchmarks or is positioned to exceed them, and we'll look at market dynamics that might be causing us to exceed it. It does have some authority to propose corrective action plans in the event a particular market participant is having an undue impact in causing healthcare costs to grow. So more to come on the Health Policy Commission, but it has, we've gotten it off the ground. It's met all of its deadlines to date, but the main work is yet to come. Other questions? Ma'am?
Fair share contribution has gone away in the under 50 marketplace. What's the status of the free rider surcharge?
Good question. I'll have to get back to you on that. I would say that nobody's ever paid the free rider surcharge. There are a number of rules that would trigger it. You'd have to have an employer that didn't offer a Section 125 plan, which is rare. And even from there, you'd have to have some meaningful portion of that employer's workforce getting uncompensated care. So I don't think that there ever has been a free rider liability triggered to date. Having said that, I don't think free rider was repealed with the repeal of fair share, so it's still there, but it has not been a sort of significant presence in the regulatory landscape to date. Correct? There we go.
All set?
Thank you.
Here we go. So Glenn, I want to thank you for a terrific talk. Obviously a man who knows his issues inside out. We'd like to present you with a Heart of the Commonwealth book, a picture book of Central Massachusetts. He can take it take it to Cape Cod on vacation when he eventually gets a break. Thank you so much, Glenn. That was terrific.
Thank you for having me.
All righty.